in pursuit of health and wisdom. Sapio with Buck Joffrey.
When I was a kid, we ate peanut butter and jelly sandwiches in the lunchroom and no one died. I'm not being facetious, that's the truth. These days, it seems like every other kid has a food allergy in school, right? At first, I thought I was just being one of those old cranky guys talking about the way things were in my day, but as it turns out, food allergy numbers have skyrocketed. Why? Is it environmental? Is it because restricting certain foods in young children like we were supposed to do a few years back actually backfired? Is it because of an altered microbiome in our intestines? To answer those questions and more, this week on Sapio with Buck Joffrey, I interview Tina Sindher, a pediatric allergist and associate professor at Stanford School of Medicine, who also serves as the director of clinical translational research at the Sean N. Parker Center for Allergy and Asthma Research. Tina explains it all. What is food allergy? Why do we get it? And what can we do about it? She also talks about some cutting edge research that's happening in the area of food allergy at Stanford and at other institutions as well. Oh, by the way, I forgot to turn the video on for the first couple of minutes of the show. Sorry about that. Just look at the still screen for a minute or two, and then you'll have Tina and me on your screen.
So, hey, Tina, how are you doing?
I'm doing very well. How are you today?
Great. Thanks for having us. So, let me just start out by asking you, just to get a little background, like how did you end up doing what you do? I mean, you are a physician, but you specialize specifically in food allergy, right? And allergy with children and that kind of thing. So how'd you get there?
Oh, yes, that's such a great question. I would say starting in medical school, I was fascinated by the immune system. And at that time, I didn't really approach allergy so much. It was more in the setting of infections and oncology and autoimmune conditions. And during residency, I got really lucky in that I got to do a rotation within allergy. Right off the intern year, July 1st, I was placed in an allergy clinic. And what I loved about allergy is there's so much unknown in the field. And at the same time, we could make a difference in a person's life in front of me. Like I could make a difference in some of our patients' lives. And it wasn't just the person that's affected by food allergy, environmental allergies, eczema, asthma.
It's your family.
It's a family affair, right? And I loved that aspect of it where it wasn't just, things happening in the lab, but I felt like I was helping someone in front of me. And I think that connection between where I get to ask the research questions, it's really fun and exciting to see how the field has evolved. But day to day, it brings me back to how can I help the person in front of me?
That's great. And along this line of, the people you're helping, it seems like there's a lot more than there used to be. I mean, correct me if I'm wrong. My perception, and I'm a surgeon, and this is not something I know a whole lot about, but I remember kids bringing peanut butter and jelly sandwiches to school, no problem. Back in the day, it was 100 years ago when I was when I was in grade school and that kind of thing. But and you just didn't hear that much about food allergies. So first of all, is that just my perception? If not, what's going on with the epidemiology?
Oh, no, it is not just your perception. It is a global phenomenon. In the past 20 years, we have seen the rates of not just food allergy, also other allergic conditions like eczema and asthma skyrocketing. Really kind of if you look at kind of the prevalence and incidence, it goes like this, and then it just, this exponential growth. And at one point we were thinking that it's really a phenomenon that we're seeing in the US and other developed countries, but we really are seeing a similar trend globally across many, many places.
I was going to ask you that. Like I remember from med school, certainly from the asthma front, that it was definitely a bigger problem in the inner cities and stuff. They were having a real problem with it. It's not like it wasn't a problem in the suburbs, but that was a major. Is the same thing true for food allergy, or is that kind of more of a a problem of the affluent?
Yeah, no, that is so. One of the reasons we think food allergies going up is kind of the way we live with kind of modern day conveniences. So, the diet we eat, if it's more processed, our microbiome, our what medications we get, and there is a lot of data, not a lot of data, but some research studies that are following cohorts that have more farm lifestyles. So they're looking at populations. There's a big Amish population in the East Coast outside of Philadelphia.
Yeah.
There are some research studies that are following their long-term outcome versus someone who's, in a city. And we do see that being exposed to farm animals can have a protective effect, and we think it has to do with the microbiome.
Yeah.
It has to do with your antibiotic usage. It has to do with just kind of dietary diversity and what you're eating.
Yeah.
So it's not just one thing. It is multifactorial.
Sure.
So it is something we have a birth cohort study right now where we're enrolling pregnant moms.
Oh, wow.
And we're following the babies up until 3 years of age to try and collecting data. We're getting skin swabs and blood work, stool samples and dietary histories, and maternal samples, paternal samples, infant samples, and just kind of trying to understand what contrioutes to this allergic progression and how can we prevent it.
Well, let's do this. First of all, there is we want to be clear. We're talking about allergy here. People have food sensitivities and intolerance as well. So how do you decipher between those definitions? If somebody is listening to this show and they know that, when they eat garlic, they've got, it makes them sick. I mean, how do you know if you have, if it's an allergy or more of a sensitivity or intolerance?
Oh, yes. Great question. And we come across this all the time where we're trying to elicit what kind of a reaction we are seeing to the foods. So our immune response to food is on a spectrum. So if we think of IgE-mediated food allergy, that is kind of what allergists are saying is your allergy, and you can develop anaphylaxis or swelling after eating. So that is on one end of the spectrum where you have preformed specific IgE antibodies that recognize the protein in the food that you're allergic to. But along that spectrum, we also see more delayed reactions. In something like celiac disease, it's an autoimmune condition. It's not IgE mediated, but IgG mediated, and that can trigger immediate responses, but a completely different mechanism. And then intolerances are a little trickier for us to identify, and there's so much of our immune response that we don't completely understand. And that's where the problem is. There's no easy test for me to say, intolerance, what kind of an immune response you're having. All I can say is it IgE mediated or not? So what I tell patients is with IgE-mediated food allergy, it is a recurring thing. Like every time you eat the food, you will have symptoms regardless of the form of food. So we use dairy as an example because it can be a trigger for a lot of people. If someone's telling me they don't have symptoms when they have yogurt, but they have symptoms when they're drinking the milk, that is not IgE-mediated allergy because the protein carries across those different forms. And if you're reacting, it's an IgE mediated, you will have a reaction regardless. Whereas if someone has very delayed symptoms, well beyond 2 hours, again, that may not be a symptom of IgE mediated allergy. That being said, there are times where it is trickier. They may present with vomiting soon after ingestion, and that's where it's really hard for us to suss out just from the story. Is it IgE mediated, as in their risk for anaphylaxis, versus something else that's uncomfortable but may not be life-threatening. And in that case, we would recommend additional testing. So
Sure.
blood work, skin prick testing, and potentially an oral food challenge.
So let's do this because, there's non-physicians listening to this too, and we're using some lingo, but I want to use, in order to just understand a little bit about the biology behind food allergy in general, take us through what's happening when a person, develops an allergic reaction to a certain food and ends up with, say, anaphylactic shock, which is, throat closing up and, life-threatening disease. So, obviously it's complicated, and I remember this stuff being very complicated, but if you can try to just sort of how should people visualize what's going on? And maybe you can define IgE in there for us too, and kind of just bring that along. I know it's kind of hard to like back up and get away from, our physician speak, but I try to do that too, but try to give us your best shot. How do you explain that to patients?
Yes. Oh, this is such an excellent question. So when I'm explaining what's happening with an allergic reaction, what I try to tell folks is it's an immune triggered process. So they have their protective antibodies, so IgG, they have IgA, and they also have IgE, which can help us fight parasites and other infectious kind of helminths and pinworms, kind of those kind of organisms. But an abundance of IgE can also be involved in providing or leading to allergic reactions that are it's not the way we want the immune system to be working.
Yeah.
And so in these allergic individuals, what we see is that instead of being tolerant to kind of harmless triggers, so environmental tree pollen or their cat, dog, dust mite, their body identifies those triggers as a foreign particle that needs to be kind of, taken care of and gotten rid of. And so they produce these IgE antibodies that recognize specific proteins in these triggers. And when a person has these preformed IgE kind of existing in their immune system, when they are exposed to these allergens, it can attach to those specific IgE antibodies, which then cause their mast cells or basophils to open up. And these mast cells, they have kind of all the cells we think of as allergic cells. So they have their histamine and quite a few other mediators there that cause the reactions that we see.
Yeah.
Notably, hives throughout, swelling, wheezing, vomiting. And so we see this full-on systemic reaction because their specific IgE antibodies have connected to their triggers and kind of triggered this full-on reaction.
Right. So in effect, you've got your immune system that's, millions of years old. These IgEs usually there for things that we don't really need to deal with anymore, like parasites and stuff like that. But it is overreactive in these situations, right? And what you've got is a reaction to something that the body's recognizing inadvertently as something that is really harmful. And as a response, it's kind of going overdrive. And because of that, you end up with a lot of these inflammatory responses, right? I'm just trying to summarize. Is that
Absolutely.
a fair assessment? And ultimately, some of these are very life-threatening. Like we talk about anaphylactic shock, which is basically an inflammatory response where the throat starts to close up, and old surgeons like me used to have to go in there and open up an airway in their throat and their trachea. So that kind of thing. So when we talk about these food allergies, are they mostly starting in children? I mean, certainly they start in adults as well, but what's the difference? Is there some key differences there?
Yeah, generally, this is something we think of as a childhood disease, that kind of, in food allergy specifically. There's also drug allergy and venom allergy, which I'm not talking about. But food allergy in general has been thought of as a childhood disease that you acquire these early in life, and it can either remain persistent into adulthood, or in the case of milk and egg, you might even outgrow it. Majority of children 80% do outgrow it naturally. But according to a publication not that long ago by Dr. Gupta in Chicago, when she looked at the prevalence of pediatric and adult allergy, what she found is a large number of adults were also reporting allergy, and some of these were new onset de novo allergy. So we are actually seeing an increase in not just childhood allergies, but also adults who were tolerant of the triggers and are now developing it later in age. And currently, at least based on Dr. Gupta's paper, the current prevalence is 8% in children. And in the paper, which was based on survey data, it was noted as 11% in adults. But anecdotally, we definitely still see mostly pediatric patients who develop food allergy.
And then a number of those kids ultimately grow out of it, right? So what's happening? Right. That is the immune system just kind of getting used to it, almost like getting allergy shots and that kind of thing. Yeah.
Mm-hmm. So for that is actually, you bring up an excellent point. We are trying to understand what is the difference in the immune system of someone who naturally outgrows their egg allergy versus someone who's persistent allergy. And there are some publications that are trying to understand the differences in their T cells and B cells, but we haven't really found a way to identify it earlier on. Because I'm imagining if I have a 1-year-old just diagnosed with egg allergy, I wish I can do a lab test and say, you're going to naturally outgrow it. No worries. Let's stay the course and we'll get there. Yeah. Or if I know early on they're not going to naturally outgrow it, then we need to prepare for address it aggressively early on. So we're still trying to understand what is it about those who naturally outgrow versus those that don't.
What is it about some of these foods that make them more likely to become things that people are allergic to? Because you kind of hear the same stuff over and over, right? Milk, nuts, that kind of thing. What is it about those proteins or specific chemicals in those that make up those foods that seems to be a trigger?
That's right. Well, our current top allergens that we list tend to be peanut, tree nuts, wheat, milk, soy, egg, shellfish. So shrimp is a leading one for adults, fish, and then sesame is a rising one. These are top allergens in most like European countries as well in the US, but we've actually tried to look at how the top allergen changes, and there are some changes across Asia, like what their top allergens are in other European countries, in Australia. So it's not always the same foods, and there are some differences among the different countries. What we think it has to do with some of the potentially the processing of the food and how it varies from different areas, and also how prevalent it is in the environment. Because what we are seeing is that, when we didn't address it quite yet, maybe it'll come up later. Part of what we're trying to understand is the development of food allergy and how it starts. Yeah. And we now suspect it may be through the skin. And so it is this competition of where we want to do oral introduction before you get kind of environmental introduction through your skin. And the only way the environmental introduction through your skin is harmful is if you have a barrier defect and you kind of have a dysregulated immune response from the get-go. So they're already kind of allergic. The reason I bring that up is that's where it's not just a matter of dietary, cultural preferences in that community, but also the environmental exposure they're getting through their skin.
Is there any data on, say, things that are common about the structures of the food, these most prevalent allergens, or not so much?
Not so much. So, for instance, peanut is very different than milk and then egg. For instance, we know that milk and egg, if you cook it or bake it in high heats, you can denature the protein. You can't do that with the other proteins. Also, what we are actively trying to understand is how, in our research, in our clinical trials, in our patient care, we found that cashew allergy has led to some pretty severe symptoms at very low doses. So we're also trying to understand what is it about cashew protein that is different than, let's say, peanut protein, and why is it triggering more severe symptoms at lower doses? So that is
it's sort of not clear right now.
Mm-hmm.
And I assume some of the cross reactivity, right? There's some, people who have multiple allergens to potentially similar types of food, and it's probably just the shape of that protein that's similar.
Mm-hmm.
Is that about all there
That's
is
right.
to it?
So with cross-reactivity, we see cashew and pistachio cross-react. So we tend to kind of use that interchangeably. So if I do oral immunotherapy with cashew, I will also, instead of doing a full buildup with pistachio, I might just say, let's just do a quick observed dose. And if it's all well, you can alternate between the two allergens. Same with pecan and walnuts. We think of them as cross-reactive, where they're cousins. So you treat one and you essentially get treatment for the other one.
Before we move off the specific topics of allergens, I have to ask you about gluten because, I'm in, we're both in California here. I'm in Santa Barbara and you're over at Stanford. Everybody and their mother seems to have some sort of sensitivity to gluten. This is not something that, again, I grew up with, and it didn't seem like people, maybe they did and it was under-recognized. Is there something, what is this gluten sensitivity that people have that's not necessarily like, celiac disease or something like that, but people just say I'm gluten sensitive. What is happening there?
Oh my gosh, that is an excellent question. I also do a clinic where it's a multidisciplinary clinic with my GI, gastroenterologist, and nutrition. So when I put on my allergist hat, as in I'm just thinking of IgE-mediated food allergy, I call it wheat allergy. I'm not worried about gluten. We don't really see, I know there are some folks who may have had an immediate reaction like that, but typically I don't come across an allergic where they're developing anaphylaxis to gluten specifically. But when I come across patients where they have a lot of just kind of problems with like IBD or IBS, and we are having a lot of trouble identifying like what is going on, their labs might be normal. One of the top things we tell them to eliminate so we can see what's going on is gluten-containing foods and dairy. They tend to cause the most symptoms in our patients where we're not able to find any lab abnormalities yet. What we do say though, because we don't want to, because what we come across, at least in our GI clinic, is in younger kids, if you do a very aggressive elimination diet, we worry about malnutrition and just making sure they get the nutrition they need. So part of our goal also is once you remove some of these foods, seeing how you're doing with your GI symptoms and attempting to reintroduce these foods back slowly to make sure you aren't reacting. So I do see a lot of gluten elimination. Some of it I think is very much warranted, but sometimes I think either some folks are getting overdiagnosed or maybe need a little more of a workup before we dive into these eliminations.
Sure. Another question, it's been a change, and I was wondering about this, is that, when my kids were born, and this was, there's 14, 11, and 8, so they're little. But I was struck by like the directives that we had with regard to ramping up various foods and holding back on certain things, and don't give this until then, and, start this at this time. There was a lot of that stuff. And again, that to me was something that was, I think my parents were stuffing anything I would eat into me, right? They didn't care. They weren't thinking about avoiding this and avoiding that. And I wonder, is there any evidence that actually having those types of restrictive policies actually contributed to the problem of increasing allergies in our country?
Yes, that's such a great point. It's something we talk about all the time, is how our guidelines have changed. And honestly, recently, if you look at global guidelines, I feel like every year you will see some new recommendation coming from an allergy society. this plot thickens, because at first we thought that these delayed introduction, or we still actively think so, that the delayed introduction may have worsened the food allergy epidemic that we see.
Right.
Because what we saw with the LEAP trial done in the UK is that even in kids who were sensitized, meaning their skin prick testing showed that they were positive peanut allergic, when they introduced peanut-containing foods, they had a far lower likelihood of developing peanut allergy down the line. And so based on the LEAP study, we've now come out with the American Academy of Pediatric guidelines saying introduce peanut early. Other studies have shown that you can get, if you introduce other foods early as well, you get that protective benefit, notably with egg and dairy. But where it gets tricky is that Australia has looked at cohort of their children and the guidelines, and they found that even after they updated their guidelines and more than 80% of children introduced peanut early, it didn't actually change the entire population prevalence of food allergy. Or of peanut allergy. And it just shows that it is so much more complicated than just, introduce early and you'll be fine. That is currently our recommendation. But what we're also looking at is how is the skin playing a role? And should we actively also be maintaining the skin barrier in addition to the early introduction to help? But this is where the immune system is fascinating. You think you have an answer and it finds a way to stump you.
Yeah. So you've brought up the skin a few times, and this is a very interesting thing that I had no idea that there was any relationship to, but I, just preparing for this interview, I've just looked, I heard one of your talks where you talked about 90% of people who end up with food allergy had eczema in their life. That's accurate, right?
That is in our cohort. I wouldn't say that's the entire kind of epidemiological, but in our clinical trials, when we look at the kids coming through, majority of them do have eczema.
So first of all, let's say, what exactly is eczema?
So that is, the term eczema is kind of this blanket term that we use. Really what we're focusing on is something called atopic dermatitis. And actually we've looked at there are some publications that say you don't even need to have atopic dermatitis. It could be dry skin. But essentially what we're finding, or what we think the process is that when little babies have dry skin all the time, it's super common. It's not even something we say to do anything about. But what we're learning is the dry skin may actually be a barrier defect that's letting in these allergens through the skin that is then interacting with your immune system in a way that you're not meant to. Like, you're supposed to ingest the foods, and it's supposed to introduce it to your immune system through the gut, but instead we're getting this introduction through the skin, and that may be what's setting us up for developing an allergy down the line. So some of our current studies are looking at that, like, if we manage the skin well, can we turn this the rate of food allergy that we're seeing.
And is there any preliminary data on that to suggest that if you do manage the skin, that you will decrease that risk?
Yes. So there are some small pilot studies and there are some large studies. And overall, what we're finding is some studies show positive benefits. Some are not really showing a benefit. We currently have a study that's looking at not just skin creams and moisturizers, but also using a steroid to make sure inflammation is reduced in addition to moisturizing the skin. We're still waiting to see what the data shows, but as of right now, it's still mixed, and we just need larger, well-conducted studies to really answer that question.
Right. So at this point, though, I'm assuming part of that is then aggressive treatment of eczema, which, is again, what you talked about with steroids potentially, and also keeping the skin moist and all that kind of stuff. What is the role of another buzzword, I guess, in terms of California, especially the microbiome here in food allergy? In other words, just for people understanding, this is, these are the the natural bacteria that live in the gut that actually are good bacteria. They help us. But I understand there may be a role of, a healthy microbiome in food allergy?
Oh, yes. Oh, yes. And this is something that many academic centers are looking into right now. Some of the birth cohorts I mentioned and the baby skin study I mentioned, in both those studies, we are collecting skin swabs as well as stool samples to really understand is how can the microbiome help or hurt this development of food allergy. So we're getting dietary information on what the babies are eating, what the mothers were eating if they were nursing, and as well as kind of how the baby does long term. So what we can say is that diversity is a good thing. So we want diverse diet and diverse microbiome, but because there's so much heterogeneity, it's been really hard to really pinpoint like these are the microbes that we want and have been protective. In terms of the skin, we're looking at the same thing. And part of that picture of atopic dermatitis, eczema, development of food allergy, we've seen that there's an overabundance of Staph aureus on the skin. So part of controlling the skin barrier involves kind of reducing that colonization and increasing the growth of other beneficial.
Yeah, and possibly some of those toxins, exotoxins, and that kind of thing and stuff. So when you look ahead at the treatment, well, first of all, let me just for people who think they might have food allergy or sensitivity, what does testing entail exactly? How do you do that?
Yes, that's an excellent question. So I wish we had better testing. I'll just preface, our current testing strategies are not the best. What we can do right now is that we have them come in and we can have them hold their antihistamines, and we have them do skin prick testing where we put small amounts of the allergen that we're concerned for and watching to see. We were talking about IgE and mast cells. It's really engaging the mast cells on your skin to see if the allergen can trigger it to open up and release histamine. And cause the little welts that we see, and we measure the welts. Also, we test for specific IgE in the blood to see if you have preformed antibodies there.
Okay.
But one of the problems we come across is there's a high false positive rate. So I don't like doing blanket testing where we're testing for every food because I worry that we'll come up with positives that may not be real. But whenever I do kind of mass testing, what I tell our families and patients is we have to take into account the clinical picture. If this is a food you've eaten without a problem, I am not worried about what the testing shows. You can continue eating the food. And if they have a history where they react, then that's, even if the testing were negative, I would say don't eat the food.
Yeah.
But really the gold standard of diagnosing food allergy is through an oral food challenge, where we will give you under and controlled environment, small amounts of the food, and watch to see if you have a reaction.
Right. So outside of avoiding the food, and obviously, a lot of people who have these severe reactions will carry around epinephrine pens to avoid having their throat close up. What are the other treatment modalities? I guess, is it primarily is it desensitization pretty much the only option really? And if that is, what is that? Maybe you can define that for everyone.
Oh yes. So one of the reasons I love this field is there's so many things being looked at right now.
Yeah.
So the top modalities outside of avoidance, which is not really a treatment, it's just avoiding, is immunotherapy. So you can have oral immunotherapy where you kind of take daily dosing of the food you're allergic to and you build it up over time. You get to what we call maintenance level, and you just take that dose every day. And the goal is it protects you from severe reactions when you have accidental exposures. Then we have something called sublingual immunotherapy. So it's almost like OIT, but you just do drops under your tongue. And then there is there is EPID or epicutaneous immunotherapy, where you put a patch containing the allergens on your skin, and it can release a low dose of the allergen. Again, daily therapy until you get up to maintenance, and you have to keep it on board to continue getting the protection you need. all of those modalities kind of need continued exposure for you to remain desensitized. If you stop the immunotherapy, you will become resensitized again. Some of the newer modalities being looked at include injections or biologics that basically suppress your allergic reaction. And you can do that as either monotherapy, meaning just the injections and not do any form of immunotherapy, and it can prevent from allergic reactions. Or you can do the injections plus oral immunotherapy, hoping that it'll minimize side effects, and then you can actually, end up eating some of the food and have it as part of your diet. So it may not just be immunotherapy. It could just be suppressing the allergic reactions, which the drug omalizumab is looking at right now, and is being explored by the FDA, and it's currently in phase 3 trial.
I'm sure there's other ones that you're excited about too that are coming along the way, but the one I'm kind of curious about, it going back to the question of microbiome, is there a role for probiotics, and what is there any studies or current studies happening on probiotics for the purpose of allergy management?
That's such a great question. So there is some work out of Australia where they've looked at probiotic therapy plus OIT, and they found that they have reduced side effects on oral immunotherapy to the food. We tried to design a study looking at that as well at our center, but the sample size that we would need, and the big dosing of the probiotics we would need, and then we're like, wait, are the side effects from too much probiotics or from the milk OIT? So we didn't end up following that through. But very small data, but within our data set, we sent out surveys to our patients trying to understand how they dosed their daily oral immunotherapy. And one of our kind of, among our patient population, what kind of stood out to us, that patients who were dosing with yogurt had lower rates of GI symptoms, which we thought was very interesting.
Right. Again, because the yogurt has, bacterial cultures in it as well.
Exactly.
Okay. Yeah.
So even though I don't quite have specific data that I can say, without a shadow of a doubt, this is what you need to do, I can't say that, but I think it's a promising area, and I am all about the microbiome, so we definitely encourage that.
Is there something that you're most excited about in terms of the future of your field right now?
Yes, I think when we are looking at all these different clinical trials coming out with all these different options, what I'm excited about is that patients will have a choice, hopefully. It's never just, this is it, this is your only path. We can actually look at the patient, look at their clinical profile, look at their allergies, and come up with the treatment option that works best for them. So really individualized, personalized care. And with these different medications that are in the pipeline, I'm really excited that we can do that.
Fantastic. Tina, this has been great. I appreciate it so much. And, just being able to talk about this and get this information out to a lot of people. I mean, these food allergies are really cryptic, right? And it's, as a physician, I mean, this is an area I know very, very little about myself, but you've done such a great job in explaining it to us, and I appreciate everything you've been able to provide us here. Dr. Tina Sindher from Stanford, thank you, and we'd love to have you back out again sometime.
Well, thank you so much for having me. This was really fun.
Thanks, Tina.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.